If it's normal, then leave it till 18. That differs from the BSG guidelines. There's more up-to-date European consensus guidelines, which I co-authored with Andrew Beggs and Shirley Hodgson, and I think that's what most European groups who have a significant number of PGS patients would recommend. And generally, a 3-yearly surveillance interval for this patient group is sufficient. Clearly, if they're one that have multiple rapid large polyp formers, you may want to reduce that interval, but as a general standard, 3-yearly surveillance is what most would recommend. So is there any outcome data? There's one study, and it's mine, 63 patients, 48 families with almost 700 years of follow-up. Interestingly, of the 2,500 polypectomies, there are only 6 polyps that contained either atypia, an old historical term, but only 4 with definite dysplasia, and all of that was low grade. People get very worried by the polyps because they have a thick, fibrous stalk, and so you do worry about post-polypectomy bleeding, the amount of diathermy and the risk of perforation. Certainly in our series we've had one significant post-polypectomy bleed. It was actually a duodenal polyp, and 2 perforations, but you can see there both those polyps were very large. And our outcome data, no luminal GI cancers, although that was updated to 1. So juvenile polyposis syndrome is perhaps the other relatively well-known hematematous polyposis syndrome. It's even more rare, so it wouldn't surprise me if many people never see this, but if you're aware of it, then hopefully if you do come across a case, it'll be flagged up in your mind, that's juvenile polyposis, I need to get somebody who understands that condition. It's rare, 1 in 150,000. It's really quite heterogeneous both clinically, but also genetically. There is clinical diagnosis criteria, which are proposed by Jeremy Jazz. So more than 5 juvenile polyps in the colon, juvenile polyps in other parts of the GI tract, or any number of juvenile polyps in somebody with a family history of juvenile polyposis. But the problem is with this, there is a bit of an overlap. So the P10 hematomatous syndromes, they often have a significant overlap in terms of the polyp, but they have other criteria which are diagnostic. There is also an overlap syndrome, which is the juvenile polyposis hereditary hemorrhagic telangiectasia syndrome. And we're seeing that more and more commonly, and that's only for those with an underlying SMAD4 genetic mutation. So what does the juvenile polyp look like? Well, the top right is the macroscopic appearances. On the bottom is the histological appearances, and should be relatively easy to distinguish this from a PGS hematoma. So they don't have that same thick fibrous core which kind of goes out in a tree-like manner. There's a significant inflammatory infiltrate, and you can see here these cystically dilated glands which often contain a lot of mucin. And so those are really the